Good morning. Welcome everybody, whoever is attending my lecture series. For today, I will be discussing on the anesthesia for the trauma patient. Classification of shock by mechanism and common causes. Hypovolemic shock, loss of blood, that is the hemorrhagic shock, external hemorrhage, trauma, gastrointestinal tract hemorrhage, bleeding, internal hemorrhage like hematoma or hemothorax or hemoperitonea. Loss of plasma, that is in burns and exfoliative dermatitis. Loss of fluid and electrolytes. External, vomiting, diarrhea, excessive sweating, hyperosmolar states, that is diabetic ketoacidosis or hyperosmolar non-ketotic coma. Internal, that is third space, like pancreatitis, ascites and bowel obstruction. Cardiogenic shock, dysrhythmia, tachyarrhythmia, bradyarrhythmia, pump failure secondary to myocardial infarction or other cardiomyopathy. Acute valvular dysfunction, especially regurgitant descents. Rupture of ventricular septa or free ventricular wall. Obstructive shock, tension pneumothorax, pericardial disease, tamponade or constriction, disease of pulmonary vasculature, massive pulmonary emboli, pulmonary hypertension, cardiac tumor like atrial myxoma, left atrial mural thrombosis, obstructive valvular disease like aortic or mitral stenosis, distributive shock like septic shock, anaphylactic shock, neurogenic shock, vasodilator drugs, acute adrenal insufficiency. Clinical classification of shock. Mild, that is less than 20% of blood volume lost. Pathophysiology, decreased peripheral perfusion only of organs able to withstand prolonged ischemia, that is skin, fat, muscle and bone. Arterial pH is normal. Clinical manifestation, patient complains of feeling cold, postural hypotension and tachycardia, cool, pale, moist skin, collapsed neck veins, concentrated urine. Moderate, that is 20 to 40% of blood volume lost, decreased central perfusion of organs, able to tolerate only brief ischemia like liver, gut, kidneys. Metabolic acidosis present. And in clinical manifestation, thirst, supine hypotension and tachycardia. This is variable, then oliguria and anuria. Severe, that is more than 40% of blood volume lost, is decreased perfusion of heart and brain, severe metabolic acidosis, respiratory acidosis possibly present. Manifestation, agitation, confusion or obtundation, supine hypotension and tachycardia invariably present. Rapid, deep respiration. These findings are most commonly observed in hemorrhagic shock but applied to other types of shock as well. Peripheral lines are usually sufficient for initial resuscitation. Massive hemorrhage depletes the intravascular fluid compartment. Fluid shifts intravascularly from the interstitial compartment to maintain the cardiovascular integrity, and interstitial fluid also moves into cells. Anaerobic metabolism leads to adenosine triphosphate, that is ATP depletion, dysfunction of the ATP dependent sodium potassium pump, and progressive cellular edema. Fluid therapy. The choice of initial fluid therapy is determined chiefly by viability. While fully cross-matched whole blood is ideal, typing and cross-matching takes 45 to 60 minutes. Type-specific blood, preferably type and skin blood, may cause minor antibody reactions but is appropriate therapy as soon as it is available, that is 5 to 10 minutes. Uncrossed O-negative packed red blood cells should be reserved for life-threatening blood loss that cannot be adequately replaced by other fluids. Complication associated with massive blood transfusions. Crystalloid solutions are readily available and inexpensive. Resuscitation requires large quantities, however, because most crystalloid solutions does not remain in the intravascular compartment. Lactated Ringer's injection is less likely to cause hyperchloremic acidosis than is normal saline. Although calcium in the former, that is lactated Ringer's solution, makes it less compatible with blood transfusions. Dextrose containing solutions may exacerbate ischemic brain damage and should be avoided in the absence of documented hypoglycemia. Even lactated Ringer's solution is slightly hypotonic and when administered in large volumes can aggravate the cerebral edema. Hypertonic solutions such as 3% or 7.5% saline are effective. For volume resuscitation and appear to be associated with less cerebral edema than lactated in gas solution or normal saline in the presence of brain injury. Although some small volumes of hypertonic saline rapidly expand the plasma volume, its use is limited by progressive hypernatremia. Transient vasodilation and hypotension may also be observed. Colloid solutions are far more expensive than the crystalloids, but they are more effective in rapidly restoring the intravascular volume. The interstitial fluid deficit associated with hypovolemic shock may be better treated with a crystalloid solution. Albumin is usually selected over dextran or hitastar solution because of the fear of inducing a coagulopathy. We come to the end of this session of lectures. I will come with more lectures in the next one.